Good afternoon. I'm Robyn Grant, Director of Public Policy and Advocacy with the National Consumer Voice for Quality Long-Term Care, or Consumer Voice for short. I want to welcome all of you to our first virtual policy briefing. There is just so much happening right now in Congress that has the potential to harm nursing home residents and other long-term care consumers, and it's all happening so quickly, literally from one day to the next, that we just felt that we needed to update you all because it couldn't wait. So we know that you didn't get much advance notice, and we want to thank you all for making the time to join us today, even though you may have already had other things scheduled. So thank you very much. We have a lot that we want to present today, so I think we're just going to go ahead and plunge in. You can see the agenda on the screen in front of you. You're going to hear first from Eric Carlson, who is Directing Attorney with Justice and Aging. Eric is going to talk about Medicaid funding cuts. And then after Eric, Sarah Rooney, Regulatory Counsel with the American Association for Justice, will talk with us about malpractice restrictions. So after that, I'll speak about what you can do about these issues, the advocacy steps you can take, and then you'll all have a chance to ask questions. So just a few logistical details first. Your lines are all muted to reduce background noise. As I said, you'll have a chance to ask questions, and you'll be able to do that by typing into the chat box. And you can ask questions at any time during the presentations, but we'll be reading them out loud and answering them during the formal Q&A part of our webinar. Just so you know, we're also recording the briefing, and then the recording and slides will be available to you afterwards. I know people always want to know if the PowerPoint will be available, and the answer is absolutely yes. So with that, I'm going to turn things over to Eric to talk about Medicaid. It's all yours, Eric.
Thanks, Robyn. You can go to the next slide, please. We're going to start by taking a quick look backwards. Why do we have Medicaid to begin with? So when this started, Medicare was created to cover acute care and physician visits and things like that, but there was a recognition that there was a gap for low-income people in general, and that included low-income older people who could make the Medicare various deductibles and co-payments and premiums in some cases. And Medicare, as we'll discuss in more detail, doesn't cover nursing facility care or in-home care by and large. And you can see the progress that's been made. There are many fewer people, many fewer older Americans living in poverty. It was much more common in the mid-60s, and we're not home free yet, but there's much improvement since that time. Next slide, please. So now we're going to look at how Medicaid works. This is as most folks probably know, this is a program that's operated jointly between the federal government and individual states. Every state participates in Medicaid, and the federal government pays at least 50% of the costs and up to approximately 3/4 of the cost. That depends on state incomes. Those states that have relatively higher incomes, by and large, get the lowest federal participation, 50%. Those poor states are going to get higher federal participation, 65, 70, or close to 75% in the most extreme instances. And the important thing to understand here is that the overall coverage is based on healthcare needs. Medical need is the standard, and oftentimes that's documented by a physician order, for example. If the care is necessary under the Medicaid guidelines, it can be provided, and and if the state needs to cover that care, the federal government is obligated appropriately to continue providing the appropriate match, whether it be 50%, 60%, 70%, or whatever. Next slide, please. The standards are set by federal law. There's some basic rules for mandatory services, for example, covered eligibility groups, things like that, nursing home reform law, for example. But then states have some discretion within that to tailor their own programs, their own Medicaid programs based on their preferences and particular state needs. So there's a lot of discretion to set within federal ranges, income standards, resource standards in some cases, the package of services that are provided. For example, there's various waivers to provide home community-based services or other demonstration waivers to test different ways of providing services. Again, a combination of basic federal structure and then some state discretion within that to set up a program based on that state's particular choices. Let's move now to the next slide, please, to some of the changes that are out there. These are the two changes that are floating around, and we're going to spend our time mostly talking about per capita caps because that's what showed up in the Republican proposal that was released a couple of days ago. But these two basic concepts are suggested occasionally. The block grants assumes a fixed amount of federal money going to the state. So the state would just get X amount this year, and then it would get X amount next year as well, multiplied by some inflation index, and then the same thing for each subsequent year. There's one comprehensive payment, purportedly comprehensive payment, but one payment only that would be indexed in some way to increase a bit. The per capita caps are similar, but the fixed payment is based on an individual. So there's a little bit more flexibility because if you have more enrollees, if you have 100 people, for example, the payment would be 100 times Y. If you had 105 people, the payment would be 105 times Y. So it's a little bit sensitive towards enrollment increases, but it has all the same limitations as the block grants. Otherwise, it doesn't respond to the actual costs or to the actual medical needs of the population. So let's look specifically at the proposal that's currently in front of Congress. Next slide, please. I imagine at this point, just about everybody on the call has heard something about this. This is the proposal developed evidently by House leadership that is now under consideration, actually today, in the House Energy and Commerce Committee. This is a proposal that proposes per capita caps, so specific fixed amount of payment for each enrollee, although that fixed payment would change a little bit depending upon which group the person is in. So X amount for the elderly, for one older person, Y amount for each person eligible as blind or disabled, Z amount for each child. You get the idea. And then it would increase by some amount each year based on what the particular inflationary index that's used. This is going to result, next slide please, in really significant cuts. It would start in fiscal year 2020, so 2019, and then extending into 2020. The cap would be set on the past fiscal year cost and then rise according to a formula based on the medical consumer price index. Significantly, this legislation doesn't have any price tags attached to it. You would expect in an important proposal like this for the proponents to have calculated out what this means from budgetary purposes. and what this means for overall coverage. But that hasn't been done by the proponents. Other folks, since it's been released, have done the math. One number is comes from the Center on Budget and Policy Priorities, a paper that was released today, and their estimation is that the Medicaid funding for older folks, people with disabilities, and families with children, the overall loss of federal funding over 10 years would be $116 billion, and then the annual deficit from starting 10 years from now would be about $20 billion annually, and then increasing from there. So, and this is, we could say, the intent of the block grant. I think that Speaker Ryan and Representative Price, who's now the Secretary of Health and Human Services, in justifying these types of proposals in the past, have been very explicit that this is about limiting the amount of money that the federal government spends for Medicaid, and it's going to have some significant consequences for Medicaid beneficiaries. And I'd note in the context of this particular legislation that the drastic cutbacks, the drastic financial cutback to Medicaid is paired with the elimination of a lot of existing taxes that primarily benefit folks with a significant amount of money. I won't detail them here, but hundreds of billions of dollars in revenue that's being foregone in this bigger package of legislation, which includes all the provisions relating to the Affordable Care Act and non-Medicaid insurance coverage. On that side of this legislation, all this revenue is being jettisoned, and it's being paid for almost exclusively with cuts focused on this very vulnerable population, the low-income folks dependent upon Medicaid. So let's take a look at older Americans in specific. Next slide, please. What's going to happen? You can imagine this very significant decrease in the capacity of Medicaid programs with real-world impacts to individuals. Next slide. Let's look at one hypothetical woman. We've called her Mrs. Elliott. She's 82 years old. Small Social Security benefit, gets a little bit of assistance at home. Next slide, please. There's a handful. I'm going to cover this very briefly. There's a handful of specific identified cutbacks, an elimination of retroactive coverage that would leave people more vulnerable to unaffordable costs at the initiation of Medicaid, and a cutback on the amount of home equity that's allowed to be retained by people who need long-term care, and the elimination of the extra match for community first choice benefits. The extra 6% federal financial participation was designed to encourage more home community-based services, and that 6% is lopped off in this legislation. Next slide, please. So let's, the bigger impact, and those are the ones that are identified, and they have consequences. The more pernicious cutbacks are the ones that aren't listed here, but that are almost the inevitable result of these drastic reductions in funding. What is it going to mean? That states are going to lose some of their optional services. There are mandatory services under Medicaid and optional services. By and large, home and community-based services are optional. What's the state going to do when looking at a huge budget hit caused by the loss of millions and then billions of dollars? They're going to drop optional services, and from the perspective of older people and persons with disabilities, this almost certainly sees a dramatic dialing back in home and community-based services, elimination of programs, institution of waiting lists, significant enrollment limitations on the programs. Next slide, please. Also the loss of other optional services. Some Medicaid services are mandatory, others are optional. The optional ones includes dental, optometry, case management, etc. A state looking for ways to save money when hit with this significant federal decrease is going to look at the optional services such as these. Next slide, please. The loss of optional coverage groups. Some coverage groups are mandatory. For example, people on SSI are a mandatory coverage group, and at least for the time being, they continue to be mandatorily covered under Medicaid law. But what you'd likely lose would be the optional coverage under Medicaid. One is the medically needy group, which is oftentimes referred to as spend-down eligibility by people. This is for beneficiaries. Let's assume Mrs. Elliott had a little bit too much money to qualify for mandatory coverage, but she had significant health care expenses. Given that, the medically needy eligibility recognizes that the person, like Mrs. Elliott, can't cover her medical expenses. She may have slightly too much income, but that's more than taken up by the health care expenses that she's looking at. Medically needy programs are common in states, but likely would be lost given the magnitude of the federal cuts that are contemplating. And then moving on to the next slide, that this may be, for the purposes of this call, the most likely consequence. Eligibility for nursing home coverage and home and community-based services. As people on the call likely understand, states have standards to determine whether somebody qualifies. Numerical scores are common. For example, a person has to have deficits in certain deficits in activities of daily living, and maybe they'd be characterized as needing full assistance or partial assistance. States use different methodologies, but the result is a system that grants eligibility if a person has a certain documented inability to do this, that, or the other activity of daily living, or needs a certain type of nursing service, whatever it is. What's the state going to do when faced with these huge budget holes? We know what happens from past experience. States change their eligibility criteria. Maybe before it took a score of 15 to qualify. Now it's going to take a score of 25 or 30, whatever it is, based on the system. And what does that mean? That people like Mrs. Elliott, who currently might be eligible for care in a nursing home, for example, or assistance with home and community-based services, won't get that coverage anymore because they will be taken out of eligibility by the change in the eligibility standards. And then finally, looking at the next slide, there's also some likely loss of access. What happens when there's big financial pressures on programs? They cut provider rates as well, which if there was a provider speaking on this panel, I'm sure he or she would point that out very vociferously. It happens, and particularly in Medicaid, provider rates being chiseled down and chiseled down and chiseled down. And if under these really draconian proposed cuts to the federal coverage, states would no doubt look at that further beyond the current levels and make further cuts, which would make it more likely that providers would walk away from the program, and that beneficiaries like Mrs. Elliott would lose access to providers and to services. Next slide, please. So what is this? I think it's fair to characterize this as rationing. What is rationing? Rationing is some arbitrary limitation on health care, right? Not based on what people actually need, but on some other arbitrary number. And that's what we're looking at here. Not coverage based on medical need, but based on a certain amount of money provided by the federal government without regard to particular costs or just without regard to the reality of what healthcare costs at that particular time and what individuals need. If there's no flexibility to adjust for increased healthcare needs, for example, people are pointing out to the increased expenses of opioid addiction, the hepatitis C medication, and just as the population ages, if the Medicaid population is more heavily comprised of, say, 85 years old people rather than 75-year-old people, just because the population is aged, that has a consequence. But this isn't going to account for that. So next slide, please. Robyn, at the 5-10 minutes from now, we'll talk more about specific advocacy steps. I'll just point out a couple of things related to messaging. Here's a bare bones description of what people might want to say. This legislation, the American Healthcare Act, the Republican proposal, the Affordable Care Act repeal, has proposals that are going to dramatically decrease federal funding and cap it going forward. It's going to starve the Medicaid programs. Medicaid is incredibly important for older Americans, and people then should also personalize the message as to why Medicaid is important to you, to your family members, or other friends that you may have. So with that, I'll pass the control over to Sarah to talk about some other legislation that's making its way, hope not too far, through Congress right now.
Hi, everyone. I'm going to talk to you about a bill that's moving through the House of Representatives that has to do with restrictions on medical malpractice claims. The bill is H.R. 1215. It's called the Protecting Patient Care Act, and it was introduced by Mr. King from Iowa. And it was quickly, there have been no hearings on it. It was quickly marked up in the Judiciary Committee, and we believe it's headed pretty quickly to the House floor. And the reason why you should care or have an interest here is that it not only does it restrict medical malpractice claims, it would restrict almost any type of claim a nursing home resident might have, and that would include restrictions on claims for things like an intentional act against nursing home resident that may happen while they're in a nursing home. And so I'm just going to run through some of the provisions here in the bill. The first initial problem, I think, is it has a sweeping definition of healthcare lawsuit, and that provision would include your typical run-of-the-mill medical malpractice claim in which a doctor is negligent in treating a patient, but it would, as I mentioned, is so broad that it would also cover nursing home claims. In addition, it would also cover most claims in regarding drugs and devices, pharmaceutical products. And some of the provisions that are most egregious is, first of all, a $250,000 cap on non-economic damages. Non-economic damages are the type of damages you get for things like pain and suffering and loss of consortium, things like that. $250,000 is an extremely low number for that, and also disproportionately impacts senior citizens, women, and children because they traditionally don't have as high economic damages and solely rely on non-economic damages to recompense for their injuries. So artificially capping that recovery at $250,000 in any type of claim, regardless of how much damage has actually been done, is pretty egregious. The next thing also has to do with the amount of recovery, and the bill eliminates joint liability, joint and several liability, and that is the legal concept in which you proceed with a claim against all possible parties who have participated in the negligent act that caused the claim, and that one party couldn't be, even if there are are 2 or 3 parties that potentially played a part in the negligence. If one party is found responsible, he's responsible for the entire judgment. And so this bill entirely undoes that concept. In addition, there's a limitation on statute of limitations of 3 years. That's significantly shorter than most state law. So a party would only have 3 years in order to bring a claim. And oftentimes I would note that, people don't have the knowledge they need to bring a claim until longer than 3 years. In addition, it has severe restrictions on attorney fees. I think that's just a way to limit the number of claims that are brought. And so all of these things are extremely important. That is because I think, the ability to have your claims addressed in court provides an important layer of protection for nursing home residents to ensure that the nursing home is behaving properly and appropriately towards all of their residents. And these restrictions all work together in order to ensure that there is not going to be the same type of access to the courthouse that there ordinarily would be. And when there is sort of a problem or something has gone wrong, there's some sort of negligence, someone is harmed, they aren't going to be fully restored in the way that they should be, because it puts so many artificial limitations on what a court can award. So all of these provisions are pretty disconcerting. We're expecting, as I said, a vote on the House floor soon, and then we'll hope it will proceed over to the Senate. And I think that's the full update on the medical malpractice bill, and I think I'm going to kick it back to Robyn for...
Yes, that's right, Sarah. Thank you very much. And thank you to Eric. So now that you've heard a bit about what's happening and maybe are depressed as many of us are, let's talk about what all of us can do about it, and hopefully end on a more positive note here. Next slide, please. Okay, the essential point here is to contact your members of Congress. And when we're saying members of Congress, we mean your U.S. representative and your 2 senators. So you have, I think, no idea the weight that you as a constituent carry. Your member of Congress is going to pay, trust me, far more attention to you than to us. And I really can't stress that enough. When we walk into offices, we're always asked about constituents and what they're saying, and trying to make that connection back to people in their own state. So there are a number of ways that you can contact your representative and senators. I've listed them here. The absolute gold standard is to meet with them. Members of Congress have district offices, so you can set up an in-person meeting, right in the state. If you can't make that happen, you can also set up a meeting by phone. We're seeing more of those take place these days. You could set up this phone meeting with someone in the district office or actually in the DC office. And I will promise you that Consumer Voice can help you with the process. So in terms of setting up meetings, we're happy to work with you on how to do that. We can help you with talking points. We can even be on the phone with you if you want. So we're offering what I'm going to call concierge advocacy services. We'll help you every step of the way. That's how important it is for you as constituents to reach out to your members of Congress. So that's the gold standard, but if you can't do a meeting, write a personal letter. That personal aspect is what makes the difference. So for instance, if you're a family member and you have a relative who may need nursing home care or any type of long-term care, talk about how you and your loved one would be affected by drastic cuts in Medicaid. Talk about what you need and what would happen if the funding wasn't there for that care. If your member of Congress supports cuts, hearing a personal story makes an impact. It really may make him or her think a little bit differently about this issue. So the fact also that you've taken the time to write something down and to write something personal really can have a major impact as well. So that's if you're a member of Congress is supporting cuts, but if your member of Congress, say, is opposing the cuts, your story is going to shore up his or her opposition and is going to give them something that they can actually use in their fight. We're being asked right and left for stories because members of Congress want to be able to make their point, those who are opposing the cuts, and when they have a human, a real story, that makes a big difference. So yet another way that you can contact your members of Congress is by calling their DC office. So the number that you have in front of you is the number for the Capitol switchboard. When you call it, you get an automated message that just directs you depending on whether you want to talk to your representative or your senator. So from that point on, then you would be connected to the office of your member of Congress. And at that point, you can go a number of different directions. You could actually, at that point, ask to talk to the healthcare staff person. So that's the person who works with your member of Congress on, obviously, on healthcare issues. So if you are then actually connected with that person, you want to be prepared in advance to talk very briefly, about how this issue affects you or someone that you love, and what action you want the legislator to take. So you want to do a wee little bit of homework beforehand, thinking about what you're going to say, because you're not going to have very much time to do it, because it's not like you've set up a meeting in advance. You're just calling and you happen to be connected. Often you may have to leave a message and be called back, but it's if you're prepared to have that conversation, or at least a brief conversation, again, that's the personal touch that really can make a difference. But you can also call and tell just whoever answers the phone that you're calling to ask the senator or representative to vote against cuts, or to vote against the American Healthcare Act, or against HR 1215, or for whatever you're actually working on. So this is a little different. This doesn't carry that same personal touch as actually connecting on directly with a person, or connecting through a letter with your story. So it doesn't have the same weight as a direct personal connection, which is always best. But I want you to know that it still counts, and it literally counts. Members of Congress count the number of calls that they get for and against a bill, and they tally them up, and they look at them, and it's a factor that they take into consideration. So calling and even just saying, I like to ask the senator to vote against, a certain bill, helps. It's an advocacy action that can help make a difference. So if you don't want to do the call, one last option that you have here is that you can respond to one of our probably many action alerts that we send out. We have an online advocacy system that allows people to send messages directly to their representative and members of the Senate. All you have to do, you don't even need to know who they are, although it's always a good thing to know who they are, but all you need to know is your zip code, which hopefully is not too much of a stretch for folks. So we are going to be sending out a couple of action alerts, I know, in the very, very near future. One will be around the Medicaid cuts, another one around the medical malpractice bill that Sarah talked to you about. So one thing you can do with our action alerts is you have the option to personalize the email message, and we'd really like to encourage you to do that. I mean, this is one of probably the easiest steps you can take, but it adds a personal touch. You can get into that message, and I promise you it really will take no more than just a couple of minutes to alter it in such a way that you're indicating why this issue matters to you, why it's important to you. And that alone is going to help that message carry more weight than an email that looks just like 100 others. But again, and I really want to stress that, if you can't do a visit, you can't do a personal letter or a call, please send an email through our system, because again, the numbers are counted, for and against. So always, 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 some action is better than no action. So if all you can do for whatever reason is enter your zip code and click submit and send that message, please do, because you are weighing in. And because you're a constituent, your voice matters. It really, really does. I think people often feel disempowered that, oh, what's the point? It doesn't make a difference. I'm just one person. Well, I'm here to tell you it does make a difference. We've heard this directly from legislators. As constituents, your voice matters. So please, please, please use it. Next slide. So usually we stop at this point, but because this issue, particularly this issue of Medicaid at this point of time, is so critical, we are hoping that you'll step up to the plate and really go the extra mile and do more this time. So the second action that you can take is to also contact the 4 key leaders that are listed on the slide. These are the members of Congress who are over the House and over the Senate, and because of that, they are very powerful. You're not their some of you are their constituents, but most of you won't be, but call them and tell them not to cut Medicaid. We want to flood their offices if we can, so that they get this message. Also, governors are coming into play. That is not always the case, but it certainly is this time round, because those cuts are really going to impact your state. Your governor is going to care. Call your governor and ask him or her to oppose Medicaid cuts. The governors, many of them are turning out to be some allies in this particular battle. So please add them to your list and give them a quick call as well. Next slide. The third action you can take is to get others to do what we've just asked you to do. Forward the action alerts that we send to you to people you know. Everybody knows people. You have friends, you have family, you have maybe a faith community, you have buddies. Send it to people you know. You could even post, I know people that have posted links on their Facebook page, and that has reached a lot of people. So think about using social media. That's available to you as as well. Talk to other people about them. Bottom line is, Medicaid is the way that we pay for long-term care in this country, and you're going to be hard-pressed to find somebody who is not being affected by the need for long-term care now or who won't be shortly. This issue touches everybody, so talk about it, email about it. Okay, next slide, please. Okay. We are, action step number 4, we're launching a Medicaid story campaign. So we'll be sending you instructions for how to get those stories, and we'll also be providing you with questions that you can use when interviewing somebody. We'll send you a consent form so you have permission. We'll also send you some examples. Next slide, please. So you can give us written stories in any way that you can. They can be written. You can even do video clips. A very short video clip can be very powerful. I actually experimented. I used my smartphone and made a very short video of a couple of residents, and it passed the Robyn test, which means that if I can do it, I guarantee you absolutely everybody on this call can do it. And it actually turned out pretty well, and it turned out to be pretty easy. So really consider doing a video clip if you can, because being able to see somebody's face is just very, very powerful and very meaningful. So, be looking for an email from us. We'll give you instructions and guidance in how to do this. Next slide, please. So as part of our story campaign, we're issuing a challenge to each state to provide us with at least one story, hopefully more, but at least one. And when you think about it, if every state did that, we'd have 50 stories, which would be absolutely fantastic. So please help us make that happen. We're going to post a map of the United States on our website. We're going to track what states have submitted stories. We're going to be publishing who submitted stories and who hasn't in The Voice, which is our electronic newsletter. So I don't usually do this, but we are into public shaming and outing the states that haven't submitted stories yet. We are really determined and committed to getting stories from every state. And this is a direct response to the fact that we've been doing Hill visits, and every single office that we have gone to has asked us for stories. That's how important they are. So we rely on all of you who are out there in the field and have that direct contact with residents and other long-term care consumers and their families to talk with those folks and get us their stories. I cannot stress to you how important that is. So with that, I think we're ready for the Q&A part of the call. Alicia, do you want to give people, or could you give people some directions for what they need to do?
Sure. So if you have a question, you can ask it in the question box. We've had some questions coming in throughout the briefing, so I'll pick out some of them and we can go from there. But I'll continue to monitor the new questions that are coming in.
Perfect.
So our first question is actually for Eric, and the question is, when appropriate, can you clarify what the rationalization key messages are that the GOP has for doing this, other than that the federal government will just spend less money?
Well, honestly, I don't think there is another reason. If you think about capping this at a per capita basis, it's or a block grant basis for that matter, it's based upon spending less money. I don't know if there's a policy reason for it. I guess if you do it, you'd assume that you're spending too much money, and maybe you're assuming that you're spending money inappropriately, and so the remedy is to spend less money. But I guess to be fair, the bill does include, in addition to the per capita caps, some other smaller provisions like the ones that I highlighted, the limit on retroactive eligibility, the dialing back of home equity, and some other things. There's a couple other that I didn't mention as well. One deals with the situation of lottery winners applying for Medicaid. Not that there are that many lottery winners out there, I think, but a couple other things like that. So I think that the architects of this, architects may not be the right word, but the people who wrote this would point to those things and say that there's some policy justification behind them. But the bill overall, those provisions are, I think, in impact completely swallowed up by this very drastic limitation of the amount of money that's going to be available. And if we're just focusing on the concept of paid out based on a fixed amount, per capita fixed amount, for example, I don't think there is really a justification aside from spending less money.
Thank you, Eric. Our next question is someone who's asked for whether we could send out a document that could highlight the points that advocates and consumers can bring up with their congressmen. And actually, I think Eric, Justice and Aging already has such a document, if you would like to elaborate on that.
Well, I pasted into the question and sent it out a model letter that we wrote a couple of days ago, and maybe Consumer Voice or others have something as well. But the model letter just focuses, I think, on the same things that we discussed. That Medicaid's important, particularly for older people. It pays for long-term service supports. This legislation would gut Medicaid and starve it from funding. It would lead to cutbacks. Please protect older Americans by opposing this legislation. Those, I think, are the basic points that can be communicated in just a couple of paragraphs, and I'm sure I'd be happy to share that, and I imagine there's a mechanism for sharing this document and some others with everybody who registered for this, and I'm sure we'd be happy to do that.
Yeah,
so this is Robyn, and
go ahead, Robyn.
I was going to say we're happy to work with Eric. I mean, obviously his document is already out there, and so we can certainly get that out to you. We're certainly going to be sending out an email alert, which will have talking points in there. In fact, it will have a tailored message on both of these issues. So we will also be working with you, Sarah, to come up with the key talking points around the medical malpractice bill as well. So good question, and information and talking points are coming.
Great. Another great question we had was from an advocate. She said that some of us work in one zip code with one congressional representative and live in another. Is it okay to make a professional contact and a personal contact?
This is Robyn. I don't see any reason why not. I think for the most part, you probably want to go with where you live. That's probably what might carry the most weight, but certainly there's no harm with making a professional contact as well.
Great, thank you. Another advocate has asked whether we think there will be demonstration projects for implementing the block grant system, or will it be started in full all at once?
I think it will be started in full all at once. The whole idea of this is for the the federal government not to have responsibility for what the states do. So there's not going to be any monitoring or demonstration projects or standards or anything like that. The funding cutbacks are going to be put into place, and the states are going to have to respond to it, and they're going to make whatever cutbacks they feel they have to, given the significant decrease in federal funding. So again, going back to the point that I started with, that I think you can characterize this, the structure of this, as a way for the federal government to separate itself from what happens. And so because of that, I wouldn't anticipate anything like a demonstration project. In fact, I would expect the opposite.
Thanks for clarifying that. Another question that we have is, under a per capita cap structure, will new regulations be potentially affected? For example, Medicaid managed care regulations or the new nursing home regulation?
Well, not automatically. So the fact that there would be reduced funding by itself doesn't change the fact that the regulations exist. And this is assuming that nothing else would happen. But just the implementation of funding caps without anything else doesn't repeal or pull back the nursing facility regulations or the Medicaid managed care regulations. I think it makes implementation and enforcement of them increasingly difficult. And there's some, I've heard some talk of the funding cuts being the first step, and the second step down the road when states are screaming, we don't have any money, we're starving out here, then the federal government says, okay, well, we've got no choice, we're going to have to eliminate this, that, and the other thing. So it's unclear that it would play out that way. It's possible, but I think that although the bottom line is it's still the states are going to be put in a bad position. The states are going to, something's going to happen if you cut back the federal financial participation by what ends up being like a 15–20% decrease in their percentage participation. There's going to be consequences, and you don't know exactly what they are, but you can imagine them being very harmful to all Medicaid beneficiaries, including older folks and people with disabilities.
So this is Robyn. I'll jump in and add to what Eric said. The survey and certification system, whereby you have state survey agencies that send out surveyors to conduct the annual survey and complaint investigation, is funded in part by Medicaid. So if Medicaid overall is cut, that is going to impact the training that's available to surveyors. It's going to impact probably the number of surveyors, how many positions can be filled. It's likely to lead to maybe more turnover, less qualified surveyors. All of that can also have an impact on the quality of nursing homes, as Eric was saying. So it's not something that people are often thinking about, but that's a real concern. And I know that everybody is aware of the problem with staffing in nursing homes right now, with provider cuts that are definitely out there on the horizon with this. We're going to be seeing, I'm sure, even lower staffing levels as staff get cut with the facility receiving decreased reimbursement funding. So there are lots of tentacles to this and a lot of impact.
Thank you, both Robyn and Eric, for answering that question. I flagged another important question from an advocate who lives in a blue state. She's wondering if it's important for her to connect with her legislators.
Absolutely, absolutely, absolutely. One of the things that we've been doing is going around and talking to, Democratic senators, for instance, and they've all been, concerned about the proposed cuts, and are coming in kind of shored up their position. It made them, I think, increase kind of their strength and their sense that they're supported in doing this. We also, asked them to reach out to their colleagues. So blue state advocacy is absolutely important. So thank you.
Great, thanks for answering that. So we have a question about HCBS waitlists. An advocate wants to know how they can be eliminated at the start of the per capita cap.
Yeah, I saw that question. Good luck. I think that the implementation of the caps are just going to make it worse. So if the state already has a wait list or an enrollment limitation, it's hard to imagine the state loosening those as a result of these per capita caps. It's going to get worse rather than better. You can advocate. I'm not saying don't advocate for it. The advocacy would be you're still under the Americans with Disabilities Act, that you're still obligated under the ADA not to unnecessarily force the unnecessary institutionalization of people. So that argument remains, but the financial pressures going the other direction would be significant.
Thank you, Eric. I guess to go along with that, another HCBF question. Someone asked, are there any caps in the bill / in current statute or rule on the federal level around how many points a state can require on a functional eligibility assessment for HCBS or long-term care? Or can states make eligibility as unattainable as they want?
There are no fixed standards. I know that's frustrating. Different states have different standards. And at some point, you have to say that if the state had something that was just completely ludicrous, that it would be subject to challenge. But there's nothing fixed. There's no federal standard, and we were involved in unsuccessful litigation on that point a few years back. So it's a somewhat difficult argument to make, and that's why this is dangerous, because there is realistically some flexibility in how the states sets these standards.
Great. So I think I'll pick one last question given our time. One advocate wants to know, how quickly must all these advocacy steps be taken?
That's an excellent question. Our hope is to do advocacy that impacts what's in the House right now. So we're hearing that the next 2 to 3 weeks are really, really critical. And we know that the medical malpractice bill is coming up for a vote, I believe in committee, and then we'll be hopefully maybe it'll die there, but we'll be moving on in the next couple of weeks too. So I would say to the extent that you can take action in the next 2 to 3 weeks, that would be ideal.
And I'd say,
but action. Go ahead, Eric.
I should just immediately, I think, is another message. You could just sort of feel that try to figure out where the tipping point is, and they're early and often.
Early and often, right. So Alicia, thank you very much for handling the questions, and we'll just wrap up. I just want to thank you all again for joining us. Obviously, these are challenging times. Nursing home residents and other long-term care consumers are really facing really more serious threats, I think, than ever before. But I really believe that all of us together can make a difference. So please send us stories. Take action at whatever level you can. If you've never responded to one of our action alerts before, I would say that this is the time. I think we're all going to want to know that we did our part and that we all did everything we could. You are great advocates, and we have a great network, so let's do it. Join me in thanking Eric and Sarah for their presentations, and thank all of you for joining, your past advocacy and your future advocacy. Talk with you again soon. Have a good rest of the afternoon.